Good afternoon, ladies and gentlemen. Mr. Chairman, I hope that you are not too tired this time of the afternoon. And I will shift gear from surgery to regular thing that we are dealing with. And this is the carotid artery disease that we can detect with our tools, in our ultrasound tools. And the point is that we know that the burden of vascular disease is huge if you take the stroke and MI all together. And we also know that most of our stroke patients will not die from the stroke. They will die from the heart. The question is, how can we assess this in a silent prior to the occurrence of this coronary artery disease or MI, because we know that in many instances the coronary artery disease, the diagnosis often come too late, and many of the MIs and some of them fatal MIs will occur without any prior chest pain or angina. So we have this our toy, and this is the ultrasound toy, and we can measure the intima medial thickness. In this audience, I don't have to repeat what is the IMT and how to detect it in a semi-automatic or automatic edge devices or software. So what we know about IMT and cardiovascular risk? There have been several population-based studies, and we all familiar with a long time ago with the CAPS study, where the carotid atherosclerosis progression study, where they evaluated about 7,000 patients and with the IMT, and basically what they found, without going into details, that basically the CCA IMT is a very good predictor of MI. And you can see there's the hazard ratio increase to 1.43 when you have an increase in IMT. The ARIC study, the atherosclerosis in the community study, which was done in the United States, again, more than 7,000 patients were followed, and the risk of coronary artery disease, this was standardized ultrasound machines and evaluation, and the risk of coronary artery disease increased gradually with the IMT increase. And as you can see, per 0.19 millimeter increase of common carotid IMT, the risk of coronary artery disease increased substantially in men and women. So definitely IMT is a predictor, or an increase or progression of IMT is a predictor for coronary artery disease. And they have reevaluated in 2012 the measurements of the IMT, and they basically found that the common carotid artery intima medial thickness is as good as measuring IMT plus plaque burden, which many people think that, okay, we should measure not only the common carotid, but we should measure also the bifurcation, the ICA, and the bilaterally, etc., which is a very elaborating studies. But they concluded, without going into details, that basically the common carotid IMT is as good as measuring the arterial tree with the IMT and plaques. The Rotterdam studies, again, came to the same conclusion. This is, again, population-based study, follow-up longitudinal study with almost 8,000 patients, and they found that the odds ratio for stroke per standard deviation increase of IMT is 1.41, and also 1.2 for myocardial infarction. So again, another piece of evidence to show that in a population basis, not selected and enriched population, this is population-based studies, the IMT may have a predictor or additional prediction for myocardial infarction in those, some of them, with silent sort of coronary artery disease. However, having said all that, not everybody agrees that IMT is the best tool to measure all this prediction of coronary artery disease. And David Spence from London, Ontario, is championed the fact that he's commented on this paper here that found that basically the plaque measurements and the plaque burden is much more suitable and predictor of coronary artery disease and cardiovascular disease rather than the common carotid IMT. And basically these are the data to show that if you look at the blue, you see that it's a carotid plaque compared to the red triangles with the carotid IMT. The best fit is the plaque rather than the IMT. And this is from these were from the population-based studies, and these are from the not the population-based study, but again the hospital-based studies. So there are many other papers to show that actually the plaque is more closely related to coronary artery disease than IMT, but I'll leave you to discuss whether CIMT is better than measuring the plaque. In my opinion, and I'll show you immediately our data, that the plaque probably is a better way to the IMT is a better predictor for an easier one to measure for prediction of coronary artery disease. This is the very known and famous study done by Pierre Amorenko and his group in Paris when they did an autopsy of patients, 803 consecutive autopsies of neurological patients, and they found, and they look at coronary plaque, coronary stenosis, and myocardial infarction, and they found amazingly that 72% of the patients will have coronary plaques, and 37% will have coronary stenosis, and about 40% will have myocardial infarction. And of these, some of these, or most of them, were actually, 2/3 of them had only silent coronary artery disease. They were not known to have coronary artery disease. And this is basically a very important piece of information that we have to know that if you compare those with stroke and those with other neurological diseases, those with stroke will have more coronary disease than expected. And therefore, we need to basically evaluate all our stroke patients, not necessarily those with carotid artery disease, but just strokes, and to evaluate their coronary, even if they don't have any symptoms and they have silent coronary artery disease. So the prevalence of coronary plaque, coronary stenosis, and MI was about 79% or up to 46% myocardial infarction in presence of plaque in any segment of the extracranial. So if you look at the extracranial arteries and you find plaques anywhere, you may predict that this patient might have coronary artery disease either with stenosis, without stenosis, or even silent myocardial infarction. So this is a very important one. This is just to show you in what is done in what is presented in the paper, and that's just the same as I said. That if you look at no plaque, or stenosis greater than 30%, or occlusion of the arteries, you may see that those with cerebral arteries and internal carotid arteries, stenosis, or plaques may have increased in coronary artery disease altogether. So he published, and the same group published another study of the prevalence of coronary arteriosclerosis in patients with cerebral infarction. At this time, they took only patients, not just autopsies, but patients with stroke, and they evaluated about 405 patients with acute stroke, and of these, 342 patients with not known coronary artery disease. So about two-thirds of these patients didn't have any known coronary artery disease. And of these, 315 underwent coronary angiography. Median about 8 days after the stroke. And again, the coronary plaque angiography in this patient, 62% of this patient and have coronary plaque. And if you look at coronary stenosis, mind you, these are patients with not known coronary artery disease. If you look at this, about 1/4 of them will have coronary artery stenosis greater than 50%. So definitely, and you can see this here, this is a study that was on this 350 patients without any known coronary disease. You can see that if you have plaque in the carotid artery, the first line, or you have plaque in the femoral artery, somewhere in the arterial tree, your likelihood to have coronary artery disease increase by 2 to 4-fold. I think that this is a very important message. And we have done our own study with the cardiologist. It's called the TAPAS, very spicy study, where we try to find the prevalence of concomitant carotid and coronary arteriosclerosis in patients who has come for coronary angiography. Each one of them basically went under carotid evaluation, including IMT, and basically we try to find out, these are all non-stroke patients, and we've tried to find out whether how many of these have asymptomatic carotid artery stenosis or plaques without knowing the results of the angiography. They all done these coronary, these carotid studies prior to the coronary angiography. And we identified, this is a study population, it's prospective study, it's still ongoing study because we are trying to correlate many other parameters and predictors, inflammatory marker, etc. Now I'll present only the carotid plaque results. And we are talking about, and this was done by a single technician, so there is no bias into the, and this was done with B-mode ultrasound, measuring the peak systolic velocity and measuring the plaques. And the coronary artery severity was identified by the cardiologist from severe stenosis. Significant coronary disease was defined as greater than 70% stenosis in the major epicardial artery or left main. 1,400 patients were recruited at that time when it was analyzed, and these are basically the results. If you look at the left-hand side is the carotid artery stenosis. If you look how many had moderate to severe stenosis, it's about 12%, and mild stenosis, the rest was 40% were normal arteries and 45% had only mild non-stenotic plaques. And these are on the right-hand side, you see the results of the coronary angiography. And if you look at the correlation, there is an increase in the coronary artery stenosis from moderate to severe compared to the, in relation with the carotid artery stenosis. The higher the carotid artery stenosis, the higher the likelihood that this patient will have either moderate or severe or left main artery stenosis on the coronary angiography. And if you look at the frequency of carotid artery disease severity by degree of coronary artery disease severity, you see that if you have 3 vessels occlusion, you're more likely to have severe arteries, carotid artery stenosis. If you have 2 vessels, it's less, etc. So the higher the stenosis, or the higher the number of coronary artery disease, the higher the likelihood to have severe or moderate to severe carotid stenosis. And the predictors were 3 vessels, coronary artery disease, and left main were predictor of carotid artery stenosis. So, having said all that, I think that from IMT to plaque and the clinical events, we should pay more attention to our stroke patient and learn more about their coronary artery, even though they don't complain of any coronary symptoms, etc., because I think that you can go from asymptomatic carotid to events, but we may prevent all these events by treating the patient properly and evaluating their coronary artery either with non-invasive techniques in order to avoid and to prevent myocardial infarction and fatal myocardial infarction. Thank you very much.